I've got to apologise now because I've got an awful lot to get through, to cover, what I need to cover. And I'm reassured by Heather James that the people in this room have got, you know, some reasonable knowledge that you do know a little bit about Aniridia already, because I will be kind of whipping through the basics quite quickly to get on to the sort of more juicy stuff, if you like. So as we've heard, Aniridia is one instance about 1 in 40,000. Most patients present as a baby with some lack of iris, but it affects the whole eye. It's a whole eye disease. The vision is normally reduced, and most but not all people get this nystagmus, the involuntary eye movements, and an abnormality at the back of the eye. Can you all hear me? Is that okay?
Yeah.
As per the inheritance is mostly isolated, that is, there's no formal syndrome. However, as we'll hear in a minute, there are other medical things that can occur even though it's not part of the syndrome, and it's dominant inheritance, and in 2/3 it's familial, and most have a PAX6 gene mutation. Or you can have WAGR syndrome, in which there are other things, including Wilms tumour and genitourinary abnormalities, and that's when you have a deletion of both PAX6 and the adjacent Wilms tumour 1 gene. It's harder to say what the inheritance is because of the genitourinary abnormalities, people may not always have children. And the iris change, is, after which it's named, is usually the most obvious abnormality, but it varies from almost no iris at all to some iris, to lots of iris, but it's not normal. And sometimes you get some funny shaped pupils as well. The back of the eye problem is called foveal hypoplasia. So fovea is the very central part of your retina that codes detailed central vision. And hypoplasia just means either not enough tissue or not enough structure, or in this case a bit of both. So most normal people's eyes, the central part of the retina has more pigment, it's darker than normal, it has a tiny pit in the middle, a depression called the fovea, and blood vessels avoid the area so as much light as possible can get in. And as you look at it, the left of the slide, there's an image called an OCT image, which is a cross-section of a normal retina showing the little pit, but on the other side is an Aniridic fovea, where there's just no structure, the blood vessels go straight across, and it looks like any other bit of retina. You can also get some changes in the nerve of sight, the optic nerve. Again, mostly hypoplasia. So on your left, there's a normal sized nerve. In the middle, there's a sort of small, misshapen nerve. And on the right, there's a thing called a coloboma, where there's a lot of tissue of the optic nerve missing. And there are other things. People with Aniridia are more likely to have strong glasses, prescriptions, or refractive error is the medical term. You may have a squint, known as a strabismus, same thing. A lazy eye, known as amblyopia, same thing. And a ptosis, a droopy lid, for reasons unknown. But there are also these problems that come on later pertaining to what people were saying about, having to cope with further visual loss later on. These tend to be more the lens problems, corneal problems, glaucoma, but also sometimes the consequences of having surgery, which can lead to further problems later. Going through lens problems briefly, although cataracts tend to come later, you can have problems in the lens early on sometimes. You can have congenital cataracts, which are usually small dots in the centre or the pole of the lens, which is shown on the right. In the middle, you've got a thing called a persistent pupillary membrane, where the bit of embryonic iris in the middle that should have died to give you a pupil remains. And you can also get a tunica vasculosa lentis, a tunic of blood vessels across the lens, which is something normally only seen in the womb, but this can persist. But those are all a bit more rare. So most people who get a problem with the lens in Aniridia will get this later in life, not be born with it. And most commonly it's a cataract, a clouding of the lens, and most of the time they look like any other, cataract that people get, in older age. The lens in the eye is suspended by some little strings called zonules, and for some reason these are weaker in people who have Aniridia. And this may allow the lens to slip out of place or sublux, so that in the bottom left picture you've got a lens which only covers half of the pupil, it's kind of slipped upwards. Keratopathy really just means pathology or disease of the cornea, but you get a sort of specific type of involvement, specific type of keratopathy in aniridia. Again, it tends to be later. Not everyone gets it, but it does tend to get worse with time. And it's due to the failure of the stem cells in the limbus, which is the little area at the edge of the cornea, as it blends into the white of the eye. In the limbus live the little cells which can multiply to repopulate the surface of the cornea. I mean, cornea is a little bit like skin. You are constantly shedding cells and creating new cells. Your corneal surface is constantly regenerating. And in keratopathy, the stem cells fail, they can't repopulate the cornea, and so it gradually gets covered by a different membrane, which is either abnormal or rather more like the membrane on the white of the eye, the conjunctiva, which is not as clear and has blood vessels in it. So initially you may start off with just features which look a little bit like a dry cornea. Later on, abnormal blood vessels start to grow in at the edge of the cornea, and later on you get a non-transparent and opaque membrane with blood vessels in, covering the cornea. The cornea underneath becomes scarred and loses transparency, and at the end stage you may get what's called keratin, which is the kind of dry, flaky stuff you get on your skin, you start to get on your eye, so the eye surface actually starts to become more like skin. And these are just a few, that shouldn't come up, should it? These are just a few various pictures of the keratopathy in different stages and in different areas of the cornea. But you can see it can be really quite bad, and the cornea can go very cloudy. Another thing that comes later on is glaucoma, or pressure in the eye. This is when the drainage channel in the eye doesn't drain the fluid inside. Pressure in the eye rises and causes gradual loss of tissue in the nerve of sight, which is known as cupping, because the little cup or hollow in the optic nerve becomes larger as nerve tissue is lost. And there's a picture there of a normal optic nerve and then one with a great big cup. And this causes progressive loss of areas of the field of vision, which is shown both in a visual field test there and also in what a patient might experience in their sight. Most people with aniridia don't actually get glaucoma, fortunately. It tends to be rare in small children and comes on later. It's diagnosed by tonometry, which is shown there, the pressure measurement in the eye, plus measuring the field of vision and the nerve appearance. But because all the tests that we do are quite difficult and delicate, it can be difficult to diagnose in small children, and they sometimes need to be put to sleep to have a look for it. Now this comes to what we were talking about a bit before regarding these central nervous system or brain abnormalities. Certainly there is some evidence that, there's good evidence that there can be reduced smell in aniridia. There can be problems, as we've said, with the processing of hearing in the brain, and there is a suggestion there may be cognitive, mental problems, emotional, behavioural problems, developmental delay, but as Veronica said, this is, we're not completely clear why or how or whether how strong a link that is. But certainly what we can say is that if you do MRIs or CT scans of the brain, you can find a number of changes in many aniridics. And I'll just try, and I've just got a couple of pictures here for anyone that can see them. The top one shows there's a little arrow for anyone who can make it out, showing a little white strip called the anterior commissure, which connects both sides of the brain, and on the left that's missing. And lower down, the arrows point to the olfactory bulbs, the bulbs you use for smelling, and on the other side, they're just not there in an aniridic. In terms of how we diagnose this, really it's examination of the eye, it's taking the history from the family and examining family members, and genetics. There are a number of conditions which can look somewhat like aniridia, and sometimes it can be very difficult to tell the difference. There are these various things called developmental anomalies of the anterior segment, meaning the front of the eye. Things like Peter's anomaly and Axenfeld-Rieger's. Whether they're all different things is difficult to say. But anyway, you can see there are lots and lots of other things you can be born with if you haven't got a normal or enough iris. People can also get confused with albinism, where the iris is abnormal. There is foveal hypoplasia and nystagmus, and sometimes it can be subtle. And other things like collobomas of the iris, shown below, where there's just a bit missing, but everything else is fine. Now, getting on to the treatment, which is really what we're here to talk about in this talk. Really, it's firstly, when they're babies, it's about assessing if there's a risk of Wilms tumour, because Wilms tumour can kill you, so you just need to make sure that they're not going to get that, or if they are, you know, be monitored. So that's the kind of first thing that everyone panics about a bit. Then there's what I call the kind of general looking after, the longer term things, and then in terms of the longer term things, there's medical management and surgery, and we'll go through some of these. So I'm not going to dwell on this. So the initial thing is using the various tests to look for a deletion of the two genes together, the PAX6 and the Wilms tumour. And there's usually sort of decent-sized bit missing. And if there is, you can do karyotyping, which is literally peering down a microscope, looking at the chromosomes and see if there's a great big bit that's not there. But it can be more subtle than that. And so you can use tests like FISH, which is where you use little fluorescent things that attach to the genes, and more modern techniques such as array testing, but really just ruling out the possibility of WAGR. And then general management. And a lot of this is something that we might consider for any child or anyone really with visual impairment, actually. So the first thing is to check if there's a glasses prescription and prescribe the appropriate glasses, no matter how young. If the vision stops developing well in one eye, they get a lazy eye or amblyopia, that might need some treatment in terms of patching the good eye. If there's a squint, they might treat that, and we'll come to that in a moment. People obviously can be light sensitive because they don't have a functioning iris or pupil to keep out the light, so you may need tinted or photochromic lenses. Probably one of the most important things we do is put people in touch with people who can actually help them. So the vision impairment teachers or developmental teams, social services, people that can give advice and counselling on ensuring that if they're children, that the vision impairment doesn't affect their general delay and help with education, etc. Low vision aids, so people can access visual material. And of course, as we've said, an audiology assessment, or some kind of detailed assessment of the hearing, just to make sure that's all right. You don't particularly want to be both vision impaired and hearing impaired. Strabismus, or squint, when the eyes don't point straight, is not uncommon. Glasses will often straighten the eyes, and may straighten the eyes enough that nothing further is needed. We then monitor people while the vision develops up until the age of 7 and give either glasses or patching to help any laziness of the eyes. And surgery can be undertaken, but in most cases it's done for normalising the appearance of the eye alignment rather than actually making the sight better, which is rare in squint surgery. But occasionally squint surgery is done because people get double vision, because the eyes are not pointing straight, or they have to keep their head in a very abnormal position because of the deviation of the eyes to see, which can get very uncomfortable. So in terms of what we do, just very, very briefly, each eye is controlled by 6 muscles to maintain the eye position. There are sort of 4 which do up and down and in and out, and there are another 2 which pass obliquely or diagonally across the eye, which can do interesting things like twist and rotate the eye. And the idea of squint surgery is essentially to isolate one or more of the muscles on the eye, grab it with a stitch so it doesn't disappear from underneath you, and move its position on the surface of the eye to either strengthen or weaken it and turn the eye position around. And that's pretty straightforward and a very common thing we do, particularly in any sort of child's ophthalmic practice. Another area of interest is contact lens use, and there are a number of different reasons why people may benefit from contact lenses in aniridia. The first might be to correct the vision, but particularly if there's very high glasses prescriptions, that can be difficult to manage with glasses, or if the surface of the eye is very irregular, you may get much better clarity of vision with a contact lens. You can also use contact lenses to improve the eye appearance, in other words, to make it look like there is an iris and pupil when there isn't, or if the surface of the eye has become white, you can just make it look dark by putting a coloured contact lens on. Tinted lenses may also reduce glare and light sensitivity, and some specialised contact lenses, particularly the very large scleral lenses, may help improve dryness on the eye surface by holding fluid against the surface of the eye. And there are loads of different kinds of lenses. There are coloured ones and there are non-coloured ones, there are hard, there are soft. The picture, I don't know if anyone can sort of see it down on the left, shows on the fingertip a normal gas-permeable contact lens, and then next to it a scleral lens, of great big ones that cover the whole surface of the eye. And they're very good for people who can't tolerate lenses or people who need more wetness on the eye. And on the other side, you can see somebody who's actually got surgical, they've had trauma, so they're aniridic not because of, aniridia, if you like, but because of surgery. And they've then got a cosmetic lens underneath, and you can see how that restores potentially the normal appearance of the eye. And you can, in fact, combine lenses that make your eye look okay and seeing contact lenses. But all of this for aniridics would really be quite specialist contact lens care, and would probably be done by somebody who's a real sort of optometrist who's got a sort of hospital-based optometric interest or has a lot of experience in ocular conditions. Having said all that, actually there's tons of problems about trying to use a contact lens in people with aniridia. Because the eye surface is irregular and abnormal, because it's dry, they're often very difficult and uncomfortable to tolerate, and actually there may be a risk of damaging the eye, causing corneal ulcers. And also they're small and fiddly, and if you're visually impaired and you've got nystagmus and all the rest of it, it can be quite a palaver, potentially, to look after them. We can't find them when you've dropped them, etc., etc. So in practice, there are not actually that many aniridic people who are regular contact lens wearers, but there are these options that I thought you'd be interested to hear. And then a big part of once you've kind of done all the diagnosing, you've got the sort of kid, getting the right support and all the rest of it, a bit of a deep breath, and then there's the kind of the rest of the life to deal with. And this is really sort of from our medical point of view, is really looking at people, screening people for glaucoma, whether it's done by the hospital or an optician or wherever. Everybody with aniridia will need screening at least once a year for life, because they may get glaucoma at any stage. And then either looking out for or monitoring the other bits and bobs that may come along, depending on how bad your eyes are. Okay, so starting off with cataract. So cataract is when the clear lens inside the eye, which lies just behind the pupil and iris, it should be transparent, it becomes opaque. And technically, any loss of transparency in a lens is technically a cataract, but most people tend to use the word to mean enough cloudiness that it's impairing your vision. It tends to come later on, whatever that might be. You're not born with it, so in childhood, early adulthood, late adulthood. Initially, symptoms tend to be of sensitivity to light, of glare, particularly driving at night. Early cataracts make the light scatter. And one-eyed double vision. You start to see multiple images in each eye because the lens starts splitting the light. But later on, the vision starts to become blurred and eventually actually reduced in clarity. Now, cataracts don't really hurt you as such, and in most cases, cataracts can be left alone inside the eye without actually damaging you. And the initial treatment is usually just changing glasses, because they often do make the glasses prescription change quite rapidly, and you may get the vision back just for the glasses lens. Many people, whether aniridic or not actually, who have cataracts won't need an operation. They'll be not too bad and they can just carry on. And the decision to operate, again, in anybody with cataract, because you don't have to take it out, is based on balance of the risks of the procedure versus how bad you are, and therefore how much benefit you're likely to get by removing the cloudiness. And then in particular in aniridia, we have to take on board the fact that there are extra factors in the eye to consider. But in anyone having the surgery, the principle is that we remove the cloudy lens from behind the pupil, and we normally would replace it with an artificial new plastic lens, or intraocular lens, IOL. And the trick of the procedure is to retain the little membrane within which the cataract lives, called the capsule, because you need that to put your little lens on, otherwise it tends to kind of drop down to the bottom of the eye and be a bit useless. And the technique, this is a nice one, you go, yes, I know. Oh no, okay, right. You'll come to the next slide. And the technique would be called phacoemulsification and intraocular lens, or IOL implantation. That's the name of the procedure. Before the operation, we have to perform what's called biometry, which is essentially taking some measurements of the curvature and the size of the eye, which allows us to calculate the power, not the size, but the power, the strength of the lens that goes inside your eye, because there is a whole range, just like glasses lenses, every person will need a different powered intraocular lens. The picture just shows what happens in sucking the lens out. So most cataracts generally are done under a local anaesthetic, i.e. the patient is awake, and we use either drops or an injection around the eye so that you don't feel the operation. In an average cataract, in an average healthy eye, you'd probably say to people, expect a 20-minute procedure. But even in normal eyes, this can be anything from 10 minutes if you're slick to an hour or more if things go pear-shaped. We tend to do this with keyhole surgery, so we make a very small incision or wound in the eye of 2.5 millimetres in the edge of the cornea, and it is designed that it will seal together without a stitch. It's sort of a stepwise entry. The eye, if you just start trying to operate in an eye that you've cut open, it tends to sort of collapse and you can't see what you're doing. So we either pump fluid in the eye to keep it shaved, or when we can't do that, use a kind of glue, sort of thick, viscous stuff, a bit like egg white, called viscoelastic, to kind of keep the eye in round shape and to be able to put the instruments in and out without, scratching and poking things. We then open the little membranous bag, the capsule, with a little opening at the front, and we use this thing you can see the picture of, the FRCOphth, which is basically a little metal thing that vibrates at ultrasonic frequencies and liquidizes the lens. And it's got a little blue sheath around the outside which pumps fluid in and sucks the fluid out. And then that removes the hard centre or nucleus of the lens, and you then use either an automated or a little manual sucker, like a little syringe thing, to just suck out the soft little bits at the edge of the cataract. And then after that, you need to put the new lens in, and the picture just shows it's a folding sort of, a bit like a soft contact lens with legs, really. You can scrunch it up into a little injector, so that can go through the tiny incision, and you just inject or unfold the lens, which pops open within the capsule with this little bag of membrane, and just sits there exactly as your old lens used to. And then at the end, just check the eye's okay, check the wound doesn't leak, give some antibiotics to prevent infection, and then you're done. Now, in anybody, forget Aniridia, in anybody who has cataract surgery, despite the fact that people tend to think it's a quick laser done by trained monkeys, in actual fact, it is a delicate operation inside the eye that requires a degree of skill, and there are some significant risks. So in a normal eye, you'd probably say 95% chance everything will be fine, but there's still a 5% chance it won't be. The sort of serious things that can happen, well, one of the things that can happen is that the membrane behind the lens, the capsule, gives way, or the little strings that support the capsule, zonules, give way, and then the jelly, the vitreous jelly at the back of the eye, starts to come forward and kind of get in the way. The operation then becomes long and complex. You may not have anything to rest your lens on, and then how do you put a lens inside the eye when there's nowhere to sort of hang it on? Or you have to put it in a funny position in front of the iris, which is not ideal. Or you may put it in and hope for the best and it may drop. And also all this sort of stuff means that there's much higher risk of retinal problems and infection after the operation. Sorry, it's going to put everyone. Everyone's thinking I'm a cataract surgeon. Right on.
So like you say, you grab the lunch.
Yeah. So, other things that happen, you can have bleeding inside the eye during the operation, which is very rare but disastrous. You can get infection in the eye afterwards, which is called endophthalmitis, which is also pretty bad. You may get clouding of the cornea afterwards. And so, as I said, you kind of, the sort of things that people without Aniridia are told, there's a 5% chance something will happen or you might not get better. There's about a 1 in 50 chance that something will go wrong in the operation, and 1 in 100 chance of reduction in vision afterwards. And these are in normal eyes, okay? And there are a few other things that are not quite as bad. Those are the serious risks. But there are other things, such as inflammation inside the eye, swelling at the back of the eye, retinal detachment, really. You also can get a loss of transparency of the capsule, but that's not the end of the world because you can treat it easily with a laser, and that occurs in about 1 in 10 patients. But then you have this extra thing to think about, which is, oh yes, and by the way, you've got Aniridia, so actually there are some extra risks. Well, firstly, the visual results may be limited by what else is wrong with the eye, because it's not necessarily just cataract that's the problem. You can remove the cataract beautifully, and if you have a dodgy retina and a dodgy cornea, actually you may not see much better, so that does have to be taken into consideration. As we've said, that if you have, say you do have damage to the capsule, which does happen, to the best one in the world, it does happen. Now, in a normal eye, what you probably do is put the implant on the iris to rest it. But if you haven't got much or any iris, suddenly you haven't got anything else to leave the lens on, and then you are a little bit stuck. And then you may end up with no lens, and that creates lots of problems, partly because we normally treat that with a contact lens, and you might not be able to wear a contact lens, so there are issues like that. In addition, as we've said, the zonules, the little strings that support the capsule, are naturally weak and unstable in people with aniridia. So there is a much higher chance, either during the operation or afterwards, of the zonules giving way and the lens moving or dropping later. So that's another issue. In addition to that, because a lot of people may have quite marked nystagmus, and you normally want an eye to keep still, and you won't be able to do that, which is and that does make quite an exciting operation. So you may have to, you may have to even consider giving some people, even if you try and paralyse the eye with an injection, it still wobbles, and you may actually have to give people an anaesthetic just because of the nystagmus, general anaesthetic. And also, there may be some just difficulties actually doing the operation. If the cornea is opaque, you need to see through it to see what you're doing. So if it's opaque, you can't see what you're doing in the operation, so that may create technical difficulties. In addition, as we've said, people who have cataract surgery can get clouding of the cornea or raised pressure in the eye afterwards. Now, that if you've already got pressure problems or corneal clouding, that's in aniridia, that's more of a worry if that happens, and it's something you see quite a lot in cataract surgery. So how can we, if after all this, we decide together, yes, we are going to do the cataract operation, what can we do to try and make it, a little bit better and safer? Well, the first thing is tread very, very carefully, take deep breath, have somebody experienced who's going to do it and what have you. One of the things you might do is not use a folding lens, because that makes it technically difficult, may damage the capsule. So you may actually go back to what we used to do 10 years ago, which is make a nice big hole in the eye, stick a big unfolding lens in and put some stitches in to close the eye. That would be perfectly reasonable. It takes longer to heal up, but it's safer. You can do a number of things during the operation just to try and be very gentle, pulling on the zonules, the little strings, not just poke and prod them because they're weak. You can use special glue. You can put funny little plastic things inside the capsule called tension rings, which help give support. You can put little what's called iris hooks in, which hook the capsule and keep it in position, you hope, while you're doing the operation. And the other thing you can do, if you want, is while you're at it, stick something inside the eye to act as a sort of artificial iris, both for glare and also for appearance. So there are a number of different things. You can see one there, which is like a sort of two-stage thing with little prongs on that they kind of overlap, so it gives you an iris. Or on the other side, the little green thing is basically, it's a normal implant, but it's got like an extra green irisy bit on top of that. Problem with all these things is they're hard to put in. It means more manipulation in the eye. If you're going to put things like that in, the bottom line is you're going to significantly raise the risks of the surgery, and that's why when people have cataract surgery, most surgeons do not suggest putting those sorts of things in, because it will simply raise the risks and people are nervous.
The iris transplant, I was under the impression it wasn't a good idea to do that because it prevents you from looking in the eye as well.
I think, you mean in terms of those sorts of inserts in the eye?
I don't know.
I have Aniridia lens in one of my eyes.
Yeah.
I asked about that and they said it's fine.
No, I don't know. I wouldn't have thought stitching the iris together to make a pupil can sometimes, because so in other words, if you go back in and try and join up the bits of iris with a stitch, that might stop you having a really good look at the back of the eye. But yeah, these things inside, because they've still got quite a big pupil on them, shouldn't.
Right.
Okay.
Can I just ask quickly?
Yeah, sure.
You mentioned before the serous risk, so you talked about the minor risk and the serious risk.
Yeah.
And you said in a sighted person who gets cataract, you're talking about 5% risk for the serious complications. Does that, increase with Aniridia?
Yeah.
What sort of increase are we talking about?
Yeah, I don't know. It partly depends how bad your Aniridia is, and I think that, put it this way, if you're sort of looking for a kind of big case series of Aniridic cataracts and what percentages were, as far as I'm aware, nobody's put that out there. Actually, we could, but we haven't. And I think you probably do is you've probably got a good bet looking at how bad the Aniridia is, which is probably going to tell you how likely things are to go wrong.
I think with Aniridias, with people with Aniridia, it's not so much the Aniridia that's at risk when you have the cataract operation. Where surgeons consultants don't always want to operate on Aniridics is when they've got cataract. If they've got glaucoma, there's a risk of the glaucoma professional-wise.
Yeah, that's also
a high risk.
Yeah, that's true. I think
who would you talk to about? Would it be coming to yourself or?
Yeah, basically you give people a sort of best guess.
I know
estimate.
Won't even give me an estimate. You just
no, I think you'd have to basically you make it up. I think to a certain extent as a sort of professional guesstimate, and that I think that if you have good going Aniridia with lots of problems going on, you're probably talking about a sort of intraoperative complication up to 1 in 5. Something, not ideal happening in the operation, I would say. That's a reasonable estimate, I think. But, depending on how bad your eye was, you could up that or down that a bit, depending, Glaucoma, as we said, I'll try and sort of concentrate on the surgical bits. So, as you said, progressive. Most people get initially treated with medical treatment, which is mostly drops, which can have some issues, but bottom line is, you can use them. And surgery is generally when things get better or the intraocular pressure is really high despite appropriate therapy. We said most really little kids don't tend to get Aniridic glaucoma. If they do, I think it's said, depends who you talk to, but the kind of traditional baby operations in babies with glaucoma and Aniridia are said not to work so well. So people tend to go for these other things, which I'll talk through. Trabeculectomy is when you create essentially like a sort of artificial trap door using the tissue of the white of the eye. And you create like a little flap so that when the pressure in the eye is high, water trickles out under the membrane, and when the pressure is low, the little door shuts. And you get like a little sort of blister underneath your top lid of where the fluid is draining called a bleb. Because normally when you cut a hole in any bit of you, including the eye, normally it heals and closes with scar tissue and the opening would shut. And this is a problem, it causes failure. We often use drugs which prevent or reduce scarring called mitomycin C or 5-FU to try and stop this trapdoor closing. Again, with any operation there are some risks, and these are the risks in people without Aniridia, the trabeculectomy. The most common thing would be that it fails, it heals up and you need to do it again. Sometimes you get too much effect and fluid is pouring out of the eye, or you can see there the bleb, the little blister is not such a little blister, it's a great big thing poking out of the eye. You can get infection, you can get inflammation, you can get retinal detachment, you often get cataract afterwards, and sometimes you just lose that last bit of vision from the manipulation of the eye. Another very similar procedure is a drainage tube. And this is exactly the same, but you stick a plastic tube through the hole, which physically stops the thing closing. That's the idea. And there are various different types with ophthalmology names attached to them. It's significantly technically more challenging, and only people who are quite highly specialist in glaucoma will usually undertake this. So the risks of tubes are really as per trabeculectomy, you're doing a similar sort of thing, but you can get clouding of the cornea, which is again an issue in this particular group, basically because the tube can start poking the back of the cornea, which is the bit that keeps it clear, or the plastic can start coming through onto the surface of the eye, which is the picture there, it starts poking out, or because actually you put this channel in the eye, the pressure can go very, very, very low, and that equally can be bad for your eye. Another procedure for glaucoma is diode, sometimes known as cyclodiode laser. And this is it's very easy to do. You use a sort of probe which you stick on the anaesthetised eye, and you buzz the laser, and the light goes through to the inside of the eye, to the gland, the ciliary body that produces the fluid. So rather than increasing drainage of fluid, you reduce production of fluid. And it's very easy to do, in actual fact. You don't have to tell a specialist to do this. That's took 10-15 minutes. The problem is, and it's much safer and easier, but it doesn't have as much effect, and quite often the effect wears off and you have to do it repeatedly. And the risks of the diode laser are sort of those. So you can sometimes lose your last bit of vision and bleeding, but most of the time it's fairly safe. And in all of these glaucoma procedures, there is a much higher risk of failure in people with aniridia. It may be difficult, again, you can't see inside the eye, and you may worsen the clouding of the cornea. So in the cornea, essentially the treatment is given to reduce the discomfort and the redness and soreness, and also to increase the vision. And many people can be managed with simple medical treatment. So you give wetting stuff, artificial tear drops and ointments. If you have very thick mucousy discharge, you can give acetylcysteine, which dissolves thick mucus. You can put a plug in the lacrimal punctum, the little drainage hole for tears, and that picture is somebody having a little plug, just like a plug in a bath, basically. Stops the tears that you have escaping. If you start to build keratin, the skin-like protein on the eye, you can give keratin dissolving drops, retinoic acid. And sometimes you put a contact lens of some sort on the eye to try and improve the surface and moisten it, but that can have as many disadvantages as advantages. And then there's some surgery. And the normal techniques that we use for clearing corneal scarring are some sort of corneal transplant. You can either remove the whole cornea and replace it with a donor, which is penetrating keratoplasty, or you can remove part of the thickness of the cornea, which is a lamellar keratoplasty, and replace it with donor tissue. But the problem is that if you only do that, and you don't address the limbal stem cell problem, then it'll all come back, because you haven't addressed the primary root of the problem. So how can you deal with stem cell failure? Well, sometimes actually, you can actually, just sounds terribly basic, scrape off the abnormal membrane and try and let it heal again. And sometimes it heals with more normal tissue. And sometimes people use this amniotic membrane just as a sort of surface to protect the eye while it heals up. So that's a bit hit and miss, but it might work. Or you can try in some way to transplant stem cells. In an ideal world, you do it from your other eye. But people with aniridia usually have problems with both eyes. And even if the second eye doesn't look too bad, if you hack off a bunch of stem cells and damage them, it's soon going to look bad. So that's not ideal. You can do some sort of donor, like we do with the corneal transplant, a cadaveric donor. The problem with that is they tend to be rejected. I know somebody's speaking later, aren't they, about limbal stem cells. But there's a high risk of rejection, so you may have to go on very strong immunosuppressant drugs with all their potential side effects, possibly for life. And you can try and culture cells if you've got enough of your own. Otherwise, you might, and this is what the girls from the institute are sort of looking at, is actually culture mouth cells and try and replace the eye ones with mouth, and that's all they're sort of working on. That, I think, holds potentially a lot of promise. And then, if it's all gone horribly wrong when you're really at the end of the road and you just want to let sunlight in the eye, you can start to do heroic things like a keratopathy, which is a bit of plastic in the cornea, or the odonto-ocular keratopathy, which is the fancy tooth stuff, which did get people quite excited, but seems to have not done so often these days. I think, and finally, or the last couple of slides now, I think a lot of people are kind of worried about this aniridic fibrosis syndrome. In my experience, it's very rare to get this, but it has been reported. You usually have to have lots of operations on the eye, and you get this weird membrane of scar tissue which grows up on the back of the cornea or on the iris and lens and can sometimes push the lens forward and may cloud the eye. And you can basically just go in and nibble away at it with some instruments, surgical instruments. It may grow back, but it is rare. People sometimes get a detachment of the retina after this. It's usually not really the aniridia as such. It's usually either because you're very highly short-sighted or secondary to other operations that have had. But it does happen, and you can have it operated on, but the results are not always perfect. And there are other bits of, like we said, for instance, that one's one where somebody's had a stitch put in. This is not aniridia in the normal sense, it's again traumatic aniridia, but somebody's reformed the pupil with a little permanent stitch inside the eye. Okay, so I think in the interest of time, that's it. I'm very happy to take any questions.
My daughter is 4. She was born with cataracts and she also has aniridia. She doesn't have any artificial lenses. Her eyes are too small to have an artificial lens.
So she's had the cataracts out?
She had the cataracts removed at 4 and 5 she wears contact lenses now, both because she doesn't have a natural lens and for to help her vision as well.
Yeah.
Should I be asking for a particular type of lenses? She has a very high prescription as well.
And her lens is soft lenses.
Yes.
Yeah. I mean, I think that as long as you're having the lenses, provided by a suitable hospital optometrist, which I'm assuming you would.
Yeah.
In general, they're very good because there's an awful lot of experience in general with because we used to never put intraocular lenses in any baby or small child that had cataracts. People were nervous it would affect the growing eye. So most of these guys have massive experience of fitting baby eyes with contact lenses with high prescriptions and will know automatically what to do. And I think that really as a baby, you really are looking at soft lenses rather than any others. I mean, the good thing is that soft lenses in general are so much better than they used to be because we've now got silicon. A lot of them got silicon in, so the oxygen permeability of soft lenses. That was always the problem. If you had no lenses, you then had a really thick soft lens, and then you couldn't get oxygen in the eye, and then you have loads of trouble. Now we can use soft lenses. To be honest, they were all really quite good. So you shouldn't have to look for anything special unless she starts to get problems with the cornea later. Yeah.
In one of your slides, you mentioned about a contact lens can help because of dry eyes, and it can trap the moisture in the eye.
Yeah.
But in the next slide, you said obviously you can't use it if you suffer from like dry eye syndrome.
Yeah.
Possibly I'm a bit confused
No,
by that.
There's basically one kind of contact lens really that you can use for dry eye, and that's the big scleral. So they're hard, gas-permeable lenses, but they're massive, and they sit over the white and the cornea as well. And what you can do is you can basically you've got to get the right sort. You can fill them with a load of fluid and put them, it's basically like holding an eye bath up constantly against the eye, which might or might not work. So it's only really that sort of contact lens, and it's not something that's done very often because because of all the other problems causing difficulties with contact lenses, even using that sort of lens sometimes may not be tolerated, but it is an option.
The only problem with the squirrel lens is that when you try and put them in, you get a constant bubble.
I think you can. It's certainly difficult to get it in without the bubble.
Yeah, it is, because I tried them I tried it for 6 months and I gave up because I just couldn't get rid of the bubble, and I was just making my eye too sore.
It depends a little bit what sort. I mean, the sort of older style ones, which are not really so gas permeable, would literally have a hole drilled in them to let the oxygen in. And in those, you're always going to get a bubble of fluids in the leak out. And the newer ones are made of gas permeable material. But you're right, it's a little bit like fill it with fluid. Oh, damn, there's a bubble starting. Absolutely right. It is quite a technique, isn't it?
It is a technique.
Right.
And if you can only see out the one eye, and you're trying to do it. It's a no-go.
Also, with the lens you said about cataract, you can have an implant.
Yeah.
Normally, with my experience anyway, I've always learned that you can't have the implant lens because there's no iris for it to attach to.
Yeah, you can, because as long as you've got the membrane, the capsule is intact, so that it's literally like a sort of, it's like, I don't think I was describing it. What are they? Minstrels, minstrels, or a Smartie, where there's like, the sort of crunchy bit on the outside and the chocolate on the inside. That is what the lens is like. So you have a complete covering of membrane with the lens like the chocolate inside. You only make a really small hole in the front of the membrane, so that if you get the lens inside, it's held both front and back by membrane. So as long as the capsule is intact, that's fine. No, there's absolutely no reason why
All
you
the
can't.
consultants with the London hospitals, that's what they say. They can't give you the implanted lens for that very reason.
No, I don't think that's. I would disagree. But then, there's lots of medical opinions. There's no reason why not. As long as they don't bust the capsule. If they bust the capsule, then you are a bit stuck. Going back to what you were saying about how are they going to attach a lens inside the eye when there's nothing to attach it to.
My membranes decided the same as it was open up.
Yeah.
And according to this, it's starting to take shape. The problem is now, just on the lens that I've got just that much now there already, holding the lens literally in place.
vitiated scleral lens, and in that they actually put a stitch and actually stitch the lens to the inside of the white of the eye. But it's really difficult to do, and it does have a lot of problems. But you can, if you're absolutely desperate, you can literally just stitch a special lens to the inside of the eye when everything else has disappeared.
Can you say what hospital will actually perform the operation?
Well, in my experience, generally, there's Moorfield says it's
Moorfield.
It might be that there is some problem with your capsule. So say, for instance, they can see that the capsule or the zonules are weak. You might not have enough capsule that they can do it in you. In people in general, as long as the capsules are all right, I can't see any reason why not, personally. But without, kind of looking at your eye now, everyone's
He's called a halt there, I'm afraid. I'm sure there are more questions. But I'm pleased to say that Melanie, well, the first way to say I appreciate you, Melanie. Melanie, as has been mentioned, is our now medical advisor leading up the panel of various experts. So if you do have any questions on these kind of subjects, please contact our inquiries officer, Jay Langley, and if necessary, they will be passed on to the relevant advisor.